Are there avenues to include or expand social assistance programs under the scope of Medicare for All? And if so, how can we tell that to policymakers who may not prioritize or see these issues on a daily basis? Thank you.
Thank you for that very touching story. Our next speaker is with great pleasure to introduce Dr. Sanjeev Sriram, who's also known as Dr. America, and works with the Healthcare Justice Correspondent for We Act Radio.
All right, thank you, everyone. Can we hear me now?
Are we good?
Yeah.
Okay. Good afternoon. Oh wow, everybody like drink decaf? Let's try this again. Good afternoon. There we go. Oh, and we've got slides. That's great. Okay, thank you. It's fantastic. Okay. So I'm going to try to run through these slides as quickly as I can, but just please know anybody who wants a copy of these, they are going to be available, and all of the sites that I use and the resources are in the notes of the slides, so you'll know where the data is coming from. But let's go ahead and just run through these real quick. Okay, so a lot of people are familiar with this story. This is the uninsured rate. The bars represent millions of people. The orange line represents the rate of the uninsured. It's stubbornly high for a while, and then it declines after implementation of the Affordable Care Act in 2013. But this is a national story, and it really and so it's not quite what you experience by the state level, and the reason for that is next slide. And what you find is that the darker blue states have higher rates of uninsurance, and the lighter blue states have lower rates of uninsurance. And the reason for this experience is largely connected to a state's adoption of Medicaid expansion versus not. So next slide. The darker blue states have refused to expand Medicaid, and the lighter blue opted to expand. The three medium blue states put it up to voters whether to expand Medicaid or not. In all three of those states, voters said overwhelmingly that they were going to support Medicaid expansion. Idaho is moving forward. Utah and Nebraska, the state legislatures are finding ways to go as slow and as small an expansion as possible for political spite. But you can see that, if you remember the previous slide and this slide, just because your state expanded Medicaid doesn't necessarily mean that you experience a great big drop in your rate of the uninsured. And so, next slide. So, what all these different lines represent are all the different ethnicities that make up the United States. And the good news in this slide is that 2013 represents the implementation of the ACA. And you see all the lines are moving downward, right? Like everybody gets to experience a decline in their rate of uninsurance. The not so great story to tell from this slide is that the gaps persisted. And that is widely problematic, and it has led to this next picture, which is basically showing that when you compare the general population to the uninsured population, we have 59% of the 28 million uninsured who are people of color. And so this is, this is just a national story, right? I want to pause right here because this story is going to vary depending on what state you live in. For Maryland, it's 355,000 uninsured, 73% of whom are people of color. Now, Maryland did everything right according to the ACA and what's available policy-wise so far. They've expanded Medicaid. They've been aggressive about adopting and implementing as many ACA provisions as is possible for a state to do. Maryland has done everything as best as they can under the system, and yet we have 355,000 uninsured, 73% of them are people of color. And so it isn't enough for, for a state to vote blue. It's not enough for a state to adopt the ACA. We've actually kind of hit the limit of what we can do with the ACA, and Maryland is actually a great example of that. Another point I want to make about this picture, nobody is uninsured in America because they are unfortunate. This is not about people being unfortunate, this is about the system being unjust. I want to make sure that I just want to make sure that we're understanding that difference. People in America are not struggling with the healthcare system because they are unfortunate. It is a system that is unjust. It's a really important distinction to make between misfortune and injustice. Misfortune is fixed by like paradigms of pity, which are fundamentally useless. I can tell you this as a physician. Injustice is fixed by determination, responsibility, and accountability, which are a lot harder, but they last. Okay, next slide. Okay, so how many people in this room have heard that by the year 2040 we're going to be a majority-minority country, meaning that people of color will make up the majority of the US population? Okay, I want to just tell you that that's about 30 years late. If you're thinking about 2040, you're thinking about 30 years late. The reason why I say that is, just take a look at this one snapshot of 2015. This is the distribution of our population according to, if you were to take all the melanin and put it in the orange bars, okay, and then break all the bars up according to age. Okay, you can see that we are rapidly becoming a majority-minority country just in a single snapshot. I should have probably made this, it's going to be a couple of bullets, so yeah, if you can just hit through those, punch through those real quick. Sorry. Yeah, no problem. Okay, so in 2011, over half of our infants were people of color. Also in 2011, the underage 10 population became majority-minority in 13 states, including here in Maryland. 2014-2015 school year was the first school year that minority student enrollment in public school outnumbered white students. 2018, the people of color, this is all ages, not just kids, were majorities in these states, and in Maryland it was at 49.5% in 2018. I'm pretty sure that enough people of color have moved into the state and babies have been born to put us over that edge. And next year will be the first year since the dawn of imperialism that over half of America's children under the age of 18 will be people of color. So the reason why I bring this up is because the current system, next slide. Okay, the current system is unsustainable for what we are growing as a country. And so far I've answered the question of who are the uninsured today, who will be uninsured tomorrow if we don't take bold action. We have to talk about why. This is a big part of the reason why, is that racism by itself does not work. It has to work with a klepto-capitalism, a form of capitalism that exploits people, takes advantage of people, denies people an opportunity to expand on their wealth and their incomes. And so when you have this type of wealth distribution in the United States, where the overwhelming majority of people of color are making less than $40,000, you have 69% of Americans who don't have $1,000 in savings, and 40% of Americans who do not have $400 for an emergency. We no longer can continue tinkering with a healthcare system that is built on the idea that everyone has to have so-called skin in the game. Right now, the current healthcare system has skinned people alive. There is no skin left to give into this system. We need Medicare for All to actually recognize this wealth inequality, recognize this racial inequality, and rebuild the system such that it does not matter what you earn, what you look like, where you live, in order to access your basic right to healthcare. So the next couple of slides I'm going to make available. This one takes a lot of time to explain, but it's a really important one. I'm sorry, I'm running out of time here to go through it. But this is from the Federal Reserve. It goes into like the pain of a $400 emergency. I'm going to skip over it, but I'll be available for questions later. Next slide. And so when we look at what we've learned from the ACA, it's that Medicaid works wonders, but it really depends on where you live. Private insurance is unaffordable and unreliable. And when we look at what our people of color voters are telling us, is that overwhelming majorities want the government to be more involved in healthcare. And so now is a great time to make racial equity a cornerstone, not a vanity project of healthcare policy, but an actual cornerstone of Medicare for all. And so next slide, and I think I'm going to close on the next one after that. These are all just important points, and I think these are all ways that Medicare for All is going to make a difference for people of color. Because the coverage moves with you from job to job, it moves with you as you cross state lines, it's mobile care. This is actually huge for how we end, a big part of the coverage disparities that we see across this country. it actually is answering the way that we're moving economically as a country, because we simply don't have the kind of jobs where you're going to stay at one company with great benefits for 12, 15, 30 years, and that you can rely upon that model to provide you with health care. I just want to end on a final point saying that Medicare for All, when I talk about making racial equity a cornerstone of the policy, it's not that I believe that Medicare for All ends racism in healthcare, or that it's part of ending racism in American society. It's actually a very small part of that. To Bessie's question about how do we actually build a system that is a bit more of a distributive justice model, when hospitals and clinics have less to worry about with payment, with their finances, they're able to actually put more of their resources into people. They're able to hire more social workers to help people figure out where can we get you better housing. And they can work on nutrition programs and everything else that Bessie was talking about. So I'll be available for questions. I thank you for your time.